Hello again, and how are you? So this is part 2 of pneumothorax, where we're going now to finish up on clinical features, diagnostic approaches, and the management. My name is Winnie Barawa. So in the previously, we looked at major parts. We looked at the definition, the types of pneumothorax. If you've not watched that video, please go and get it on the links below or onto our playlist on the respiratory conditions, where you will also get amazing other videos pertaining to respiratory systems and its related illnesses. So in this part 2 of pneumothorax, let's explore further on what are the clinical features and what are the management. And if you're new here, remember to subscribe, but also to just let you know, this channel focuses on lectures, lessons, and expert interviews relating to healthcare. So on pneumothorax clinical manifestation, we describe pneumothorax as a disease where there is a wound or a hole on the chest wall that allows air to enter our pleural space and cause the lungs to collapse. So when it comes to signs and symptoms, the client will be presenting with chest pains, tachycardia. This client will come with trachea deviation. And in trachea deviation, we are talking about the trachea getting pushed away towards the area that is not affected. So for example, in the tension pneumothorax, where we said tension pneumothorax is an emergency disease because there's no exit of this air as it comes in, there'll be trachea deviation away from the affected side. Therefore, we'll be deviating this trachea to the unaffected side or towards the normal side of the lung. So apart from that, we are also having compression of organs like the heart and the major blood vessels there. So apart from this deviation, we have the heart getting compressed, and we shall also have the major blood vessel getting compressed. And it is because of this that we get the tachycardia. Then when it comes to the respiratory distress, this is due now to limited lung capacity because the lungs are getting compressed, the lungs are getting collapsed, and so they're not able to take in enough amount of air volume, and so we are not able to have efficient gaseous exchange. And the other bit is you can have unilateral absence of breath sounds. And unilateral absence of breath sounds basically explores the aspect that when this air comes into the pleural space, the lungs will collapse. And possibly when also we are taking in air or we are having inspiration, air entry will not be present in the affected lung. And so the breath sounds will be absent. And the other bit is on hyperresonance, or another aspect of diminished breath sounds again. So if these lungs are getting affected when you do the percussions, there'll be aspect of hyperresonance. The other manifestations that you need to look at also is the reduced mobility of the affected half of the thorax. That is, if you look at the changes of rising and fall of the chest, because when it comes to the chest symmetry, we're supposed to see equal rising and fall of the chest. However, in a client who has pneumothorax, you will observe that there's only one side of the chest that is rising and falling as per the required state. And because of this tells you now there is a reduced mobility when it comes to the thorax. So one side will not be moving, only one side will be rising and falling properly. Then on the other bit is observing clinical features of open and tension pneumothorax, whereby in these patients of tension and open pneumothorax, there is excessive presentation of air hunger, agitation aspects, hypotension, that is low blood pressure, and you can also have presentation of cyanosis. But in other states is patient will present with moderate to mild dyspnea and chest discomfort for the client who has spontaneous pneumothorax. So basically for the clinical manifestation, you get to observe all the way from cyanosis, air hunger, agitation, tracheal deviation, dyspnea, chest discomfort, aspect of irritability. All this will be presentable together in basically like in the observation of pneumothorax. So you may not have to cram like, how do I describe tension pneumothorax or open pneumothorax? The best thing is, can you identify generally how pneumothorax presents in our client? But put in mind that pneumothorax in terms of pathophysiology basically has air accumulating in our pleural space leading to collapsing of the lungs. And this brings us to how do we diagnose pneumothorax? So there are different approaches in diagnosis of pneumothorax, and one of the ways is chest x-ray. So the chest x-ray will help us confirm the presence of air in the pleural space, but also the respiratory examination, that is doing the physical general examination, like observing the chest to see the proper rising and fall in terms of symmetry. You can see also the lung sounds in terms of auscultation, that you will find there is unilateral absence of lung sounds. Then in blood test, you can have UECs, that is urea, electrolytes, and creatinine. You can also observe using the arterial blood gases, where you will see changes in terms of oxygen and carbon dioxide levels in the blood. There is spirometry, and in spirometry you want to confirm the lung function abilities. Is the client having enough vital capacity? Do we have enough tidal volume exchanges? How is it coming along? So with all this diagnosis, you can therefore establish the correct nature, or you can see the progress of the pneumothorax. In the management of pneumothorax, it's encouraged that you focus first or prioritize first the availability of removing the air from the pleural cavity, either by using a needle or a chest tube. Remember, the accumulation of this air can cause collapsing of this lung. So you want to happen in a way that you want to promote this lung to re-expand as fast as possible. And so the biggest approach is to remove that air from the pleural cavity, either using a needle or using a chest tube. And here's an illustration of these approaches. With the chest tube, you'll have a chest tube system, which I will describe also in detail in the next video. So the chest tube is a system that allows us to access the pleural space and to remove any fluid or air that is present in that space. So the chest tube can help us reassure that by eliminating the air or the blood and allowing the lungs to re-expand. But the other bit is to repair the trauma and close the opening on the pleural cavity. And in this case of trauma and closure, you can either use surgery or you can either use gauzes to just pad that place and close it as we wait for further interventions. We also have the aspect that because there is collapsing and the lung is not able to expand as per the required, then ensure you can administer high concentration supplemental oxygen to just ensure there is boost up of oxygen levels in our blood and the patient does not develop cyanosis. Then go for proper chest tube drainage systems. Have heavy dressing on the opening by patching and tightly dressing that wound to avoid further entry of air. The patient can also be helped into preparation for needle aspiration using thoracentesis. In the cases where there is extreme accumulation of further contents like pus, blood, you can go for thoracentesis to help you aspirate that content adequately. And the other bit is just understanding about the chest tube. But the priority approach for management of pneumothorax is understanding how to eliminate the air from the pleural cavity, either by the needle approach, that is thoracentesis aspects, or by installing the chest tube systems. So that's the biggest approach that someone needs to understand. Then the other management is basically looking at pain management at the site, giving oxygen, positioning this gland properly, and maintaining proper management of the patient. So here again, we have nursing diagnosis for pneumothorax client. So I've got through this time. We have the ineffective breathing pattern related to the presence of air in the pleural space. And then the other diagnosis we can use is impaired gaseous exchange, which could be related to development of atelectasis and collapsing of the lungs. So all these are literally featuring on the progress of pneumothorax when it comes to the accumulation of air in the space and the compression of these lungs until they collapse. So remember, with atelectasis, provided there's a collapse, there's a compression that could be inserted onto these alveoli, they can actually end up also collapsing, so leading to the aspect of impaired gaseous exchange. But these two are the priority nursing diagnoses that you need to have when it comes to management of a pneumothorax client. So anywhere you have a nursing diagnosis, please remember to have a nursing intervention. So let's look at the nursing interventions that you can imply. So we have the achievement of effective breathing pattern. Remember, we say tension pneumothorax, it's an emergency condition because you're not able to exit that air. So in the emergency care, you need to understand how to apply heavy gauzes to the chest wound to prevent further entry of air, then assist with emergency thoracentesis. I would assist with emergency thoracostomies. This is to help us, evacuate the air or evacuate the fluid that is accumulating in that space and allowing re-expansion of the lungs. The other bit is maintaining patent airways. So in this case, you need to understand abilities in terms of participating in sanctioning, positioning the patient in its upright positions to allow chest expansion, to allow enough capacity for the lungs to expand and regain their ability to expand and recoil. The other bit is learning how to manage the chest tubes, like maintaining patency of the tubes. So like assisting the patient to, do splints while turning or coughing, administering of pain medication when it comes to ensuring that the chest tube insertion sites are not inflamed or they are not pained and all that. But remember, I will do a comprehensive part of management of the chest tubes, and so watch out for the incoming videos in the next few days. The other bit is resolving impaired gaseous exchange. So this is about monitoring oximetries and monitoring the arterial blood gases to determine oxygenation needs. If you can provide oxygen as needed to ensure that the patient has balanced tissue perfusion so that they don't have or they don't develop into the status of hypoxemias or hypercapnia cases. And the other bit is educating this patient in terms of disease progress, management, and even health maintenance upon admission and also upon discharge. And lastly is understanding complications of pneumothorax. And this can vary from respiratory failure, where in the complicated case where this pneumothorax was not intervened, no management was put in place to help the patient, then you can end up with respiratory failures. But also remember, some of these diseases are recurrent, like in the spontaneous pneumothorax, there's a risk of recurrence because in this wound, there's large wound that is due to trauma most of the time, and it can easily allow air in and out. So there's recurrence if you don't manage it well. But you can also have cardiovascular complications and collapse in the cases of tension pneumothorax. So again, you need to watch out for how do you manage tension pneumothorax, but also monitor for pneumomediastinum complications. So in pneumomediastinum, we are looking at air can actually complicate and accumulate in the mediastinal space, which now brings us into another complication that is involving the cardiovascular system, which is more risky than even dealing with the lungs. So these are the possible complications for pneumothorax. So thank you for staying all the way to the end. Again, I ask you to comment. Is there any management that you feel we've not discussed and you wish us to include it into the pneumothorax video? Let us know in the comment below or in the comment section. You can share the video with your friends and classmates, but don't forget to like it if it's a very good video. Subscribe if you've not yet done. So thank you and see you in our next lessons. Bye bye.